my name is Dr. Grimm. I'm one of the medical doctors here in Uniklinik Freiburg. And my main things are endometriosis and fibroids. So this is the topic today. I would like to tell you something about endometriosis and fibroids or myomas in fertility treatment. We first start with a deep endometriosis. So what is deep endometriosis? It's organ infiltrating. It's not only on the peritoneal, it could also infiltrate into the bladder, the ureter, the bowel, and of course the sacrouterine ligaments. We normally perform a two-step surgery, so that the first laparoscopy is like a diagnostic tool to have a look if there is a deep endometriosis which infiltrates the bowel or the bladder. Then we plan a pre-treatment and a consultation before the surgery with maybe urology or general surgery. The aim of the surgery is the complete resection, like R0, as you know, by the cancer surgery, because only if you resect all the endometriosis, then it's improved fertility and pain relief. Often we perform an interdisciplinary surgery with urology or general surgery. And this needs optimal planning, so we often have the two-step surgery, but we only have a two-step surgery if it's really a deep endometriosis. There are different kinds of classification. The normal or the classic classification is the endometriosis genitalis interna, like the adenomyosis into the uterus. The endometriosis genitalis externa, it's within the pelvic but outside the uterus. And the endometriosis extragenitalis outside the pelvic, for example, diaphragma or belly or something like that, or in the scarf of the cesarean. There are also classifications like RAS-RM, and I'd like to show you our classification we use in Germany, Switzerland, and Austria. I will tell you. The classification which is international known is the American Society of Reproductive Medicine. It's an international classification. It's a classification in 4 stages. The 4 stages, 1 to 4. 4 is the worst one with the most findings of endometriosis, and it depends on the score you can give during the surgery. The criticism of this classification is that it's only for the peritoneal findings and the ovaries, not the deep endometriosis. And also excluded are the findings outside the pelvic, so the extragenital endometriosis. And if you have a patient has a surgery in another clinic and then she has a consultation in your clinic, then you read, yeah, it's an endometriosis RSS-RM stage 2, but you can't see the localization except if it's written in the surgery report. So you need the surgery report. This is very important. We have a NCIAN, or the new one, it's since 2 years, the hashtag NCIAN. It's a classification the Austrian, Switzerland, and German endometriosis league created. At the beginning, it was only for the deep endometriosis, and we have 3 letters, A, B, C, and all the letters mean a special compartment. So letter A is for the septum rectovaginale, B for sacrouterine ligaments, C for the rectum. And then you can give numbers to these letters, which shows you the size of the findings. 1 is smaller than 1 centimeter, 2, 1 to 3 centimeter, 3, more than 3 centimeters. And new, so I told you since 2 or maybe 3 years, we have the hashtag NCIAN. We only use this one. It's also for the peritoneal and ovaries and the fallopian tubes. I will show you. So this is the hashtag NCIAN classification. As you can see, we have the peritoneum here. P1 is smaller than 3 centimeters, and so on. O is for the ovary. Then you can also choose if it's on the left side or the right side. A for the septum rectovaginal, and B for the sacrouterine ligaments. C is for the rectum. FA means adenomyosis, FB means bladder, FI intestinum, FU ureter, and then you have also the option to do a FO. It's for others, like diaphragma or the thorax or nerves or something like that. Diagnostic, it's it's not easy for the endometriosis because mostly it's not seen during the ultrasound. We can only see big spots and big knots of endometriosis, or of course the endometriomas. The anamnesis is very important because we're asking for the symptoms. What kind of symptoms does the patient have? For how long is the pain, since years or only a few months? Has there already been any therapy like hormones or surgery in another clinic? And does exist a sterility? Maybe for how long, since 8 years or something like that. Did also was an ART, an artificial reproductive therapy. So these are the most important questions we're asking. We, of course, do the gynecological examination, like a speculum examination, especially if are there any findings in the posterior or anterior vaginal fornix. Mostly when you see something, it's in the posterior vaginal fornix, and the palpation of the septum rectovaginale, and a transvaginal ultrasound, including the bladder and the rectum. We are looking from the vagina. We don't do a rectum ultrasound. We just see the rectum when we do a vaginal ultrasound. And the most important thing is the kidney ultrasound, because only there you can see a hydronephrosis, because most of the patients are very asymptomatic if they have hydronephrosis. If you listen to the symptoms, then they can lead you, maybe they can lead you to the localization. If a patient has dys or hypermenorrhea, it could be an adenomyosis. If there is a dyspareunia, then maybe the sacrouterine ligaments could have any findings. Dyschezia, the rectum or vagina. Hematochezia is for the rectum, and the dysuria or hematouria, of course, the bladder. And urinary stasis is if the ureter is maybe compressed by a knot of endometriosis. Therapy is individualized therapy according to the clinical situation. If you have a patient that doesn't, or only mild symptoms, or she doesn't have any desire to have a baby at the moment, or maybe she has a new job and says, no, a surgery I don't want to have at the moment, then you can do a medication like hormones, gestagen, or something like that. A surgery we perform when there is a sterility, and of course as a diagnostic tool. And the most important, as I told you, the urinary stasis. The pain therapy is used when you have a patient with chronification or some contraindications for hormones, or maybe a surgery. Maybe you have a very ill patient, then we first try the pain therapy. But normally we perform the laparoscopy, because the patient consulting us are do have a lot of pain. The pathophysiology of endometriosis associated infertility. We have some factors that could be a problem for the sterility. The mechanical factors are like pelvic adhesions and anatomical distortion. They could affect the conception process in endometriosis. Of course, we know that it's a disease that makes a inflammation in the pelvic and fibrosis and adhesions, and also anatomical distortion and mechanical factors. Maybe it could impair the oocyte release from the ovary. It could inhibit tubal ovum pickup or ovum transport, and or block sperm transfer into the fallopian tube. Also very important is the ovarian reserve. We know that patients with deep infiltrating endometriosis often have a lower AMH, it's anti-Müller hormone. It's a hormone or a marker for ovarian reserve. This is mostly low if they have endometriomas and multiple ovarian surgeries in the past. Impaired ovulation, spontaneous ovulation rate in women with deep infiltrating endometriosis is poor and controversial. And we know that the prolactin levels are significantly higher in patients with deep endometriosis. So it's the blocking of the estrogen receptors. Also, the endometrial receptivity, defective implantation could be due to reduced endometrial receptivity or decidualization capacity in these women. Adenomyosis and other uterine factors, the junctional zone thickness and the high peristalsis of the uterus may alter the uterotubal transport as well as biochemical processes. And it's also associated with lower implantation rates and increased risk for early pregnancy loss. If we think about the reproductive surgery in the stage 1 and 2, these are some findings that are not visible during the clinical and ultrasound examination. We only see if we do a laparoscopy. So the operative laparoscopy increases natural intrauterine pregnancy rates. And for the stage 3 and 4, there are no RCTs to determine. And women with advanced disease are normally counseled towards a surgery in case of significant pain symptoms, large endometriomas, or urethra and bowel clinical involvement. The deep infiltrating endometriosis, it's about 6% of endometriosis patients. The pregnancy rate after surgery for rectovaginal endometriosis is between 24 and 44%. And meta-analysis studies on both rectovaginal and rectosigmoid deep infiltrating endometriosis patients showed a significant benefit of surgery before ART, artificial reproductive therapy, IVF or ICSI. Surgery and ART remain the mainstay of effective therapy. So if you have a patient which is had a really total remove of the endometriosis and you do an ART, it's up to 50 to 60% for the pregnancy rate. And normally surgery is generally not recommended for enhancing fertility in asymptomatic patients. Risk of surgery, of course, there are, especially for the deep infiltrating endometriosis, if you put out all the findings, especially in the sacrouterine ligaments, then it could be that a very young woman could have a bladder emptying disorder with self-catheterization. So this is, you have to think about during the surgery if you put everything away. It's also anastomotic leak if you do a bowel anastomosis, anastomotic stenosis, and sexual dysfunction, and vaginal dryness. This is all of the damage of the plexus hypogastricus on both sides. So visualizing the nervus hypogastricus and plexus hypogastricus inferior in case of deep endometriosis surgery is very, very important. I have a picture here for you. So this is the left side. You see here the left ureter and here the nervus hypogastricus on the left side. I know normally an endometriosis doesn't look like that clear because it's an infiltrating process and you often don't see the ureter very well. A special topic is the endometrioma. For me, the ovaries are very important because I also do some ART here in this clinic. 20 to 40% of endometriosis patients do have endometriomas. It's more often on the left side than on the right side. So we don't know why, but it is like that. And it's very important during the surgery to do a resection instead of fenestration, because if you only cut the endometrioma and get out all of the chocolate fluid, then there is a recurrence of 80%. But if you do a surgery, then you have to think about the ovarian reserve, because recurrent surgery, if you do a recurrent surgery, then there is a big loss of ovarian reserve. So if you have a recurrent endometrioma on the same side, then you have to think about if you will do a re-surgery. I talk to the patients and we are looking, if it's on the same side again, then we will take a blood test like the AMH that shows us the ovarian reserve. And if it's very low, so we don't do another surgery, then we recommend the patient to do an ART. So this is, you all know, this is a picture of endometrioma. So what should we do, surgery or medication? Yeah, it depends on, is the patient in desire future fertility? How is the ovarian reserve, the AMH marker? Is it on one side or on both sides, or is it a recurrence, so on the same side again? We perform hormones only if there's a patient that only has pain and only wants to get a little reduction of size. The surgery we perform if it's on one side of the ovary, not on both sides, if it's no recurrence and if we have a good ovarian reserve and the patient has pain. The artificial reproductive therapy is better to do if she has endometriomas on both sides, if it's a recurrence, if we have minimal ovarian reserve and or, for example, no pain. So you have to discuss with the patients. It's not black and white. It's a discussion and individualized therapy. Important for the surgery is as gently as possible, as thoroughly as necessary. So only if you try to get out all of the endometrioma, the recurrence is very high if you don't do a complete resection. A complete extirpation of the endometrioma is better than fenestration because of the recurrence rate, and adhesiolusis for the restore of anatomy. So this is one picture of we call it frozen pelvis. So we have the uterus right here and both ovaries glued to the uterus. So this is just an example for our hashtag NCIAN. We have here on the left side an O for ovary 2. It's about 3 to 7 centimeters, and on the right side we have stage 1, so it's smaller than 3 centimeters, but this just for your interest. Typical chocolate fluid if you open the endometrioma. I have some pictures for you from some case reports we performed in our clinic. The first patient is endometriosis and bladder findings. It's a 25-year-old woman with dysmenorrhea and dysuria, no hematuria. She had a diagnostic laparoscopy in another clinic, and they saw a frozen pelvis. And she had a consultation appointment in our center. We performed the normal gynecological examination. So if they have an appointment with me, they don't have to empty the bladder like on the left side. I just want to have it a bit filled, because then I can see some findings if there are any. So for example, here this patient, she had a finding here in or on the bladder. Here you think, oh, it's not infiltrating, but here you could imagine that it's infiltrating. So we planned a surgery with that patient with our colleagues from the urology. And this was the intraoperative cystoscopy. Here you can see the blue spots, and this dark area, this is endometriosis. So it's infiltrating in the bladder. And this was the laparoscopy finding. Here is the uterus, the right one, ovary. And here is the bladder. And because of the inflammation, there is adhesion from the meso of the sigma. So all glue on the bladder. We did a adhesiolisis and then saw the bladder and cut out this area and then closed it. So the patient is painless today, and she doesn't have any problems with her bladder. So the bladder normally heals very fine. The second one is with rectal findings. It's a, excuse me, a 36-year-old woman with dysmenorrhea, dyschezia, hematochezia, and sterility. She also had an appointment in our clinic. We performed a gynecological examination, and we saw a finding during that examination. So this is a vaginal ultrasound, and if I do the examination, I also have a look for the rectum, but from the vagina. It's not a rectal ultrasound, it's an vaginal ultrasound. Here you can see the rectum. This is a very fine rectum, no findings, but at this patient we had a finding. It's a 3 centimeter knot we saw during ultrasound. So this was a patient we already planned the surgery with general surgery standby because we knew she had a finding. These are some pictures from the laparoscopy. The gynecologist, so we performed the preparation of the rectum. This is the rectum. And then we called the general surgery, and they stapled, they cut out this area that was infiltrated by endometriosis. So here you can see the further anastomosis, and this is the part we cut off, cut out. So it's 10 centimeters or a little bit less. And here, all this area, it's not only a knot, it's inflammation, and this is the area with the deep infiltrating endometriosis. And afterwards, so we did the anastomosis, and it looks all fine. So this patient as well doesn't have any symptoms after the surgery. She had a good healing, and already was pregnant 1 year after the surgery. The next patient, or the last patient, is a patient with a asymptomatic hydronephrosis on the left side. So we always perform a kidney ultrasound. So it was very important for this patient. It's a 30-year-old woman with dysmenorrhea and dysuria, and she had a hydronephrosis on the left side because she had endometriomas on both ovaries. The endometriomas haven't been so big, but if you see here, the sacrouterine ligament on the left side is very thick. So we knew this is the knot that makes the ureter very close, so that she, or the reason why she has a hydronephrosis. We performed it together with our urology colleagues. And this is a Da Vinci surgery. This is the beginning of the surgery. You see the uterus and both ovaries here on the left side and on the right side. And she also has endometriosis here in the Douglas. And the left ovary is gluing to the uterus. So, and behind there is the ureter, and there is the finding we will see in a few minutes. We had a look on the right side. So here you can also see the endometrioma, because there was also an adhesion. Here you can see the endometriosis. Here you have a deep infiltrating endometriosis. This is only peritoneal endometriosis. And also, I don't know if it was very fast, but here on the fallopian tube, she also had a small knot of endometriosis. So first we do arteriolysis, because we have to go to the ureter on the left side. Here is the extirpation of the endometrioma on the left side. The typical chocolate is coming out. And go a bit fast forward. Yeah, so you can see this is the cyst inside. Endometriomas normally are very, yeah, you can't do a good surgery because it glues with the ovary, so you can't put it out like a functional cyst. This is the reason why endometriomas often reduce the ovarian reserve after a surgery. So this is the reason as well why you don't have, or you shouldn't do recurrence surgery in case if the ovarian reserve is also low. So I go a bit fast forward. So this is the cyst. As you can see, the wall of the cyst is very thick. This is typical for endometriomas, and you can't get them off the normal over tissue, because it's very yeah, it glues to the ovary. So this is Da Vinci surgery, and this is very comfortable for endometriosis. Not only for endometriosis, it's comfortable for a lot of surgeries. Here is the part by the urology. We open the peritoneum on the left side. The urology isn't afraid of the ureter, so they are very fast. This is the preparation. For a good ureterolysis, just to find and cut off the endometriosis finding on the sacrouterine ligament on the left side. So in this case, the urology wanted to have a catheter in the ureter on the left side so that you can feel it much more better during the surgery. A double J. The hypogastricus you've seen there on the left side here. Here it is. Go a bit fast forward. So, and this is on the underneath the ovary. Here's the ureter. And this is all endometriosis. And this is the aim, to cut all of these out so that the stenosis of the ureter will be disappeared. It's very bloody because of the inflammation you all know during endometriosis surgery. So this is the ureter here, and here you see the structure of the ureter because of endometriosis. This is all endometriosis. Go a bit fast forward because of the time. Woohoo. So this is the big knot. And afterwards, because it was a big hole in the peritoneum, then they decided to do some stitches. But yeah, you can do, it's better because if the bowel will fall into this hole, then you maybe could have an ileus. So oh, now it's closed and it looks fine. Sorry. And this is after the surgery. So the ovaries aren't adherent to the uterus. And now we perform the chromoperturbation of the fallopian tubes. So by ECG. And as you can see, all the green stuff is coming out. So the fallopian tubes are free. Okay, the second topic are fibroids. The symptoms, it depends on the localization and the size of the fibroids. 70% of the patients are indeed asymptomatic. And the main symptoms are hypermenorrhea, dysmenorrhea, and unfortunately, miscarriage. Some patients have bulk symptoms like pelvic pressure, back or abdominal pain, and a kind of fullness feeling. Bladder or bowel symptoms are urinary frequency or constipation. sexual dysfunction, and it's also associated with infertility and increased risk of preterm labor. We do the classification by the FIGO. For the submucosal fibroids, we have FIGO 0, 1, and 2, and it depends on it's a fibroid only in the cavity or more than 50% intracavity or less than 50%, and the others are intramural fibroids like FIGO 3. And yeah, you can see here on the picture, I don't know if you use it as well. We often use it. We not always, but I think it's a good tool if you write it into the ultrasound, and the surgeon who didn't do the ultrasound could think about what kind of myoma do we expect. Is there any association between fibroids and infertility? Yeah, a source of controversy with wide swings in expert opinions. 2 meta-analyses have shown that submucosal myomas are detrimental to fertility because there are a lot of miscarriage, and the ongoing pregnancy and live birth rates are significantly lower in women with uterine fibroids. So how do we treat these patients who have the desire to have children? The submucosal fibroids, they normally are very small. So the primary approach of type 0, hole in the cavum, and type 1 and 2 is the resection performed by hysteroscopic resection. For the intramural fibroids, we normally perform the laparoscopy and cut off the fibroids or the myoma. There are some mentions that type 3, close to the endometrial lining, with a size of more than 2 centimeters, may have a detrimental effect. If a myoma is intramural but not in contact with the underlying endometrium, then the cutoff is 3 centimeter for intervention, because fibroids could grow during the pregnancy. They don't have to, but could. And we talk with the patients. If she has a lot of fibroids, then we discuss if there is an intervention necessary before she realizes her desire to have children. How to manage myoma-related infertility? There are 2 options: the hysteroscopic myoma resection for type 0, 1, and 2. And skilled surgeons even could do type 3. I never met such a skilled surgeon, but you can find it in the literature. And post-hysteroscopic pregnancy rates about 45%. Laparoscopic myomectomy, there have been reports of uterine rupture as well as after a cesarean. And this is why it's very important to close the myometrial defect. And we tell the patient that she shouldn't get pregnant during 6 to, I often say, better 9 months. Post-myomectomy pregnancy rate averaging at 52%. So here I have a video as well. Well, it's again a Da Vinci surgery. So we open the serosa and myometrium to find the fibroid. Do the preparation by coagulation, and you always have to, yeah, here, you always have to be attended for the fallopian tube so that you don't cut them. Then get the myoma, and then it's just like tearing and preparating. So I go a bit fast forward because myoma surgeries are often very bloody, of course, because they have a good blood feeding. So this is a very big myoma. It depends on the localization if you open the cavity or not. If you open the cavity, then it's important to close it well. We normally do close the cavity and then close the rest of the uterus so that the cavity is well closed. So we do 2 different lines of stitches. It's a very soft myoma, so I don't know, maybe it was a adenomyosis because it's not like a golf ball, so strong. So now it's cut off. Nearly. Because of the size of the myoma, it's very close to the camera. Do some coagulation, but not too much, because if it's too dry and you did too much coagulation, it won't heal. So let it a bit juicy. So now it's enucleated. I go a bit fast forward. Yeah. Then now this is the suture. We used Stratafix. This has some, I don't know how to call, but some spikes. So you don't have to do a lot of knots. You don't have to do any knot. So we did a deep suture, and now there is the suture on the surface. And this is the uterus after the surgery. For the last thing I want you to show is if you have a big myoma and you want to reduce the bleeding during that surgery, it's possible. It depends on the size of the uterus. If you could do some clips on the arteria uterina, I would just show you for interest. We don't perform this during each and every fibroid surgery, but sometimes we do. You preparate and find the uterina. So you first have to look for the ureter, and on the distal part of the ureter, then you will find the arteria uterina. Here's on the left side, and we put some bulldogs, are they called? We put on the uterina, and after the surgery, we get it off again. So there is a normal blood flow afterwards. So you don't cut the uterina, you just clip it for the moment. Here you see the arteria iliaca externa on the left side, and the vessels. Well, you don't have to do this, but sometimes it's very helpful if you're suggesting or you think you have a lot of blood loss. So here you can see here the ureter. It was like here. There it was moving like a worm. Moving like a worm. And this is the point where you can find the arteria uterina. So it crosses. You can see it. And these are the clips. And you just put the clip on it, and this on both sides, so you could reduce the bleeding. But one more time, it's not necessary to do this, and sometimes it's not possible. Yesterday we performed a Da Vinci myomectomy, and it was not possible to do that because the uterus was so big, so we couldn't get to the arteria uterina here on this side. Yeah, how to manage myoma-related infertility if you don't want to do any surgery. You have also uterine artery embolization. But it's associated with the risk of re-surgery or reoperation. The surgical intervention is required in 15 to 20% after successful embolization, and up to 50% in case of incomplete infarction of the myoma. We don't do that. It's the radiology that performs this, but we often see the patients with a lot of pain afterwards. So they do a consult and do an appointment in our clinic to talk about maybe a reoperation. You could also do magnetic resonance guided and ultrasound guided FUS, FUS, so focused ultrasound. So there are no data available on obstetric outcome. So we normally perform the surgery. And of course, you have the medical treatment like oral contraceptives and GnRH agonists, and of course the antagonists like Rieco you could use, or if you know the selective progesterone receptor modulator like SMIA, it's good for a size reduction. It's the myomas won't remove itself. There is only a size reduction, but SMIA is known as there could be a liver failure, so you normally use it 1 to maximum 3 months. So this was the treatment of, or fertility treatment of endometriosis and fibroids. And yeah, thank you for your attention. I hope it was a bit interesting for you.